Good morning, everyone. Thank you for joining us bright and early today in Singapore. Good day to those of you who are in a different time zone from us in Asia. Welcome all of you to the first virtual conference of the Asian Society of Pediatric Anesthesiologists, or ASPA for short. I'm Olivia from KK Hospital in Singapore and your MC for today. Although this is the third time Singapore is hosting the ASPA conference, it is our first time connecting everyone virtually, and we do hope that this conference runs smoothly. Through this, we hope that we will be able to reach out to a larger audience and welcome more people to ASPA. As anesthetists, many of us would have the experience of missing that IV cannula on the chubby little infant hand. Similarly, should there be any technical glitches, we seek your patience and kind understanding as we keep calm and carry on. Since there are many travel restrictions in place due to the ongoing COVID-19 pandemic, the organizing committee have tried to bring a little part of Singapore's unique food and culture to you through our social program at the end of today. I dare say that this will be the first time that a medical conference in Singapore features a cooking demonstration and Singapore's unique take on English. So we do hope you will stay with us right till the end. Now, to our delegates who are attending their first ever ASPA meeting, I'd like to take this opportunity to share the journey of ASPA through the years with you. And for those of you who are familiar faces of ASPA, may this be a trip down memory lane for you.
We teach because we care. because it empowers.
It creates friendship.
It's with it.
It is now my honor to introduce Dr. Josephine Tan, the current president of ASPA. She has actively served as a member of ASPA since its inception, and many ASPA members joining us today will certainly recognize her as a familiar face. Let's welcome Dr. Josephine Tan.
Members and friends of ASPA, good morning and a very warm welcome to ASPA 2021, a virtual experience. The Society of Pediatric Anesthesiologists, otherwise known as ASPA, has just celebrated her 21st birthday. Since her humble beginnings from the year 2000, ASPA membership has grown from 74 to now 542 in the year 2021. ASPA's commitment to promote learning and friendship amongst pediatric anesthesiologists in Asia did not wane despite COVID disruptions and challenges. She quickly adapted, and the virtual Flex Lecture series led by Dr. Brushali and her team, and the virtual perioperative life support workshops have now largely replaced our face-to-face meetings. In addition to these new programs, ASPA promises more exciting times in the coming year, with the formation of special interest groups in the areas of pediatric pain, patient safety, and collaborative research in Asia. ASPA's vision is also well aligned with the Global Health Initiative to provide safe anesthesia for all children, no matter which country or hospital. It is indeed a tall order, but you can make a difference. Help us grow pediatric anesthesia in Asia. Join ASPA and contribute. Last but not least, I want to wish everybody well. Sit back, relax, and enjoy ASPA 2021's academic program, and don't forget to stay for the social events. Thank you.
Thank you, Dr. Jo. I'll now like to invite Dr. Xiao Yunam, the chair of the organizing committee for ASPA 2021, to say a few words and open the meeting. Dr. Xiao, please.
Good morning and good evening, everybody. Welcome to ASPA 2021. It's so great to see so many of you tuning in from different time zones. The last time I checked, we have registrants from 47 countries, reflecting the diversity and the international reach of pediatric anesthesia. The pandemic has fundamentally accelerated the way virtualization is creating new ways for people to connect, share, and to learn over distances. We hope that through this virtual conference, we will be able to leverage the new technology to learn from one another and to strengthen our communities. The theme for this year's conference is Navigating New Frontiers to Improve Pediatric Anesthesia Outcomes in Asia. So let me take you through some of the highlights of the program. We wanted to prioritize on 4 themes: the frontier part, the foundational pillars, the front-end outcome-driven areas, and of course, fraternity. First, for the frontier research. In pediatric anesthesia, the topic that has fascinated researchers for the last decade has been concerns regarding the impact of general anesthesia on neurocognitive developmental outcomes. So today, we have invited Prof. Soriano from Boston Children's Hospital to give the opening plenary on optimizing neurocognitive outcomes in pediatric anesthesia. Next, research on the use of EEG analysis to deliver individualized anesthetic care has become more widespread. And tomorrow, we have Professor Patrick Perdon from Harvard University, who will give the plenary on this very interesting topic. He and Dr. Bong Chen Lui, our scientific chair, will be conducting the EEG workshop tomorrow. Secondly, foundational pillars. That's quality improvement and education. We believe that in order to consistently deliver excellent and safe care, we need the ability to create a culture of safety powered by the engine of continuous improvement skills. For that, we collaborated with Speak Up Safe Group from North America to conduct their QI training workshop last weekend. We invited the Chief Quality Officer from NHG, anesthetist and patient safety expert, Professor Tai Hui Yi, to deliver our Day 2 plenary on the past, present, and future of patient safety. And we have dedicated an entire track to physician burnout and building system resilience. And we will get to hear how patient safety systems are implemented in different contexts in Asia. In our education track tomorrow, we will explore the use of simulation and what is in the future of anesthesia training. Third, we know that front-end specialties are the most important proximate areas where all our education, training, and research will be translated into meaningful patient outcomes. And one of the most important outcomes is pain. And we have invited Professor Alan Finley to deliver today's second plenary lecture. He will provide us an update on pediatric perioperative pain management. And we have a full-day pain track with the first ASPA Pain Special Interest Group meeting later today. Many of you have already experienced the virtual airway workshop yesterday. And over the next 2 days, we hope you will benefit from the tracks on trauma, vascular access, anesthetic nursing training, cardiac and neuroanesthesia, and more. Finally, fraternity. We believe one of the most important outcomes for organizing this conference is to build the network of like-minded people. We hope you will be able to easily connect with our speakers and panelists through the platform, and we have also organized special interest group meetings for patient safety, research, and cardiac anesthesia. We urge all of you to actively participate through the virtual platform with your questions and comments, and do let us know if you have any issues navigating the platform. We will also appreciate your feedback for the program. Lastly, before I officially open the meeting, I want to thank 3 groups of people. First, a big thank you to all the plenary and session speakers and moderators for the generosity in sharing your time and your expertise. We are also grateful to the delegates for your participation and contributions. Secondly, a word of thanks to our sponsors for your continued partnerships, without which this conference will not be possible. 3M and Medtronic for your generous support and collaboration in hosting 2 sessions later on today on the prevention of perioperative hypothermia and the use of capnography in procedural pediatric sedation. And also thanks to AbbVie, Vigon, Philips, Baxter, and Bluestone for your kind contributions. Last and certainly not least, I want to say a big thank you to my amazing department at the KK Department of Pediatric Anesthesia for putting everything aside to put this together. And a shout out to my wonderful partner in crime, Scientific Chair, Dr. Bong Chun Lui, for overseeing the program with such enthusiasm. So with that, I wish you a great conference experience. Thank you.
Thank you, Dr. Xiao. Next up, we will have our first plenary session. But before we begin, let me just share some housekeeping matters. If you have questions for our speakers, please click on the live discussion button at the bottom right-hand corner of your screen. The live discussion panel will pop up, and all questions can be entered on the questions tab in the middle for the speakers to address at the end of the session. Some tracks during the conference will include participant polls. In order to participate, please click on the live discussion button, followed by the polls tab on the right-hand side of the panel. You can start voting when you see the polls question, and we encourage everyone to participate as your opinion is highly valued. And now, I'd like to hand over the time to Dr. Bong Chun Lui, our scientific chair for this conference, who will moderate the first plenary. Dr. Pong, please.
Good morning, everyone. Welcome to the first plenary lecture of the ASPA 2021 conference. Our theme this year is Navigating New Frontiers to Improve Pediatric Anesthesia Outcomes in Asia, where we hope to explore the latest developments in the field and learn how we can apply some of this knowledge in our individual healthcare settings to improve outcomes in our patients. Thus, it is my great honor and pleasure to introduce our first plenary speaker, who is one of the most eminent figures pushing the frontiers of pediatric neuroanesthesia and neuroscience, Professor Sulpicio Soriano. Professor Sol Soriano holds the Boston Children's Hospital Endowed Chair in Pediatric Neuroanesthesia and is a professor of anesthesia at Harvard Medical School. He's a graduate from the University of Pennsylvania School of Medicine and Graduate School of Education, with concentration in medical education. Sol completed a residency in anesthesiology at the University of California, Davis, and pediatric anesthesiology fellowship at Boston Children's Hospital. His investigative work includes the perioperative management of pediatric neuroanesthesia patients, neuroinflammation, and impact of anesthetic drugs on the developing brain. Dr. Soriano gave the 45th Emory A. Rovenstein Lecture at the 2015 Postgraduate Assembly. He's the past president of the Society of Neurosurgical Anesthesia and Critical Care and chair of the Committee of Pediatric Anesthesia for the ASA. We are indeed privileged to have Sol speak to us on improving neurological outcomes in pediatric anesthesia. Welcome, Sol.
Well, good morning to my friends in Singapore and in Asia. I can't think of a better way of spending a Friday evening here in Boston than to be reunited, although virtually, with my friends in Singapore and Asia, in this fabulous meeting of the Asian Society of Pediatric Anesthesiologists. I'd like to thank Dr. Bong for her gracious introduction of myself, and she was certainly a valued colleague during her time here in Boston. I also like to thank Dr. Xiao, the chair of the organizing committee of this meeting, as well as recognize Dr. Tan, who is your president. I can't think of a better way of starting the conference by addressing issues that will help us navigate new frontiers to improve pediatric anesthesia outcome in Asia. And certainly improving neurological outcomes in our patients is a key to the success of this goal. As far as my disclosure and learning objectives, it's shown here, and hopefully at the conclusion of this activity, you'll be able to describe the current clinical research on the impact of anesthetic drugs and management techniques on neurological outcomes in infants and children. Well, this issue is not new to us, and in this review article that my colleague, Dr. Mary Ellen McCann, and I published in the British Journal of Medicine of Anesthesiology, the British Journal of Anesthesia in 2012, almost 10 years ago, we addressed the issue of perioperative central nervous system injury in neonates. And certainly, that's the height of the whole issue about anesthetic-induced developmental neurotoxicity, which has been shown in animal models, and thus raising concerns on its applicability on humans. Certainly, there is some evidence for developmental anesthetic neurotoxicity in some cases, but it's in a review of the literature, it is inconclusive. And as we state here, the specter of cerebral injury due to issues such as cerebral hyperperfusion, metabolic derangement, coexisting disease, and the surgery itself should be recognized in the outcomes of these patients. When you look at the issue about anesthesia in childhood and neurodevelopmental outcome, this editorial by Andrew Davison and Laszlo Vutskis in Anesthesiology are seeking to find whether or not this is relevant in our clinical practice, and describe this process as the ongoing hunt for this phenome. Certainly in the laboratory, such as mine in Boston, there are significant impacts of anesthetics on the developing brain, certainly by impacting cell signaling between neurons and its surrounding glial cells and astrocytes, and even in the intracellular mechanisms such as mitochondrial function, as well as calcium handling, can be impacted by the anesthetic drugs and therefore can lead to CNS injury. And certainly this is something that we should think about as we apply this knowledge to our clinical practice. In the laboratory, certainly we can demonstrate this rigorously. However, whether or not we can extrapolate these factors to the clinical setting is still undecided. The first landmark study looking at this in the clinical side was the study published by Bob Wilder from the Mayo Clinic, where he looked at patients who underwent anesthetics, either one anesthetic versus multiple anesthetics, and look at the incidence of learning disabilities over the age 5 to 20. And you can see here, if these patients were exposed to only one anesthetic, it did not change the incidence of learning disabilities compared to those who were naive to anesthetic exposure or surgery. However, when they're multiply exposed to anesthetics and surgery, you can see that there's almost a threefold rise in the incidence of learning disabilities in these patients. And certainly in your own group in Singapore, Dr. Bong has shown that indeed there may be an impact of general anesthesia in infancy on academic performance. And in this landmark study published in Anesthesia and Analgesia, you can see that they report the primary school learning examination scores in patients who were exposed to anesthetic at an early age versus naive controls. They also examine the parental assessments of the childhood behavior, very similar to the child behavioral checklist that's been described in other studies, to see if there's indeed an impact of anesthetic exposure in early age. Their study resulted in the fact that they were not able to demonstrate a significant difference in the primary school learning examination. However, when they queried their patients' parents on whether or not they perceive increased learning disabilities in those patients exposed to anesthetics, there was a 25% increase in reported learning disabilities by the parents. So certainly the parents' impression of the anesthetics, as well as thoughts about the anesthetic exposure and its impact on their children, is certainly something we should address. And certainly they're probably one of the bigger stakeholders in this whole issue. Also, sedation can have an impact on this. In this study where they looked at from Memphis St. Jude's Hospital in Tennessee, you can see in 212 patients with acute lymphocytic anemia who required propofol and also sedation for various therapeutic treatments such as radiation therapy. They were able to demonstrate that the increased risk ratio for patients receiving propofol and as well as volatile anesthetics for managing these patients during these procedures. They state that in these patients, many of them who had almost 30 exposures per child, that there was a risk-adjusted risk for cognitive impairment in these patients. However, you should look, other studies have shown that there's no difference. And in the study by Ellie Bartels from the Netherlands, she looked at the outcome in almost 1,200 monozygotic twin pairs, where one twin is exposed to surgery anesthesia, whereas the other was not. In those twins that were exposed to anesthetic drugs, they had a significantly lower educational achievement scores and more cognitive problems reported as they developed. However, their scores were not different from the unexposed co-twin, therefore showing that perhaps the impact of anesthetic drugs and surgery did not cause these learning disabilities. So when you compare the various retrospective studies that look at the impact of anesthetics and cognitive development as well as neuro development, you can see that the risk ratio ranges from 2.5 to 1. So there's no congruence between these retrospective studies. A more recent study by the Mayo Clinic group looked at a prospective analysis of their patients in their cohort and looked at the primary outcome of intelligence quotient and found that there was no significant difference between the multiply exposed patients versus the singly exposed patients. However, when they looked at these patients more carefully, they found there were subtle decrements in their neuropsychological domains that's associated with behavior and learning difficulties. Therefore, as they look at these patients more carefully, they were able to detect a trend towards neurodevelopmental disorders. Now, when we examine a randomized controlled trial, whether or not a child or infant gets general versus regional anesthesia, that is, whether general anesthesia has an impact on neurodevelopmental outcome, the only study that has come out is the GAS study from our group as well as our collaborators in Europe and in Eurasia. This study that was led by Andrew Davidson as well as Mary Ellen McCann looked at neurodevelopmental outcomes at 2 years of age, looking at the Bayley's scale of infant and toddler development, and found there was no difference in those patients who received a regional anesthetic versus those who received a sevoflurane-based anesthetic for these procedures that lasted less than an hour long. At 5 years, they implemented the Wetzler preschool primary scale of intelligence in the same cohorts and found that there was also no significant difference between the regional versus the general anesthetic group, thereby showing that for these brief exposures to anesthesia and surgery, that there may not be any impact on neurodevelopmental scores. These and other studies have led to consensus statements, particularly by our colleagues in Europe. This is from the Society of Anesthesia, European Society of Anesthesiology and the European Society of Pediatric Anesthesiology, where they found that there was no compelling evidence to change anesthetic practice, because indeed these studies are not definitive in showing that there is an issue in the way these anesthetics impact neurodevelopment. However, they caution practitioners to provide adequate information to the risk of anesthetics as well as surgery to the patients, because certainly these can develop homeostasis and impact homeostasis during the perioperative period. Now let's look beyond anesthetic neurotoxicity, and this is a review of considerations to lessen the risk of neurological injury. And in the case of our conference, let's apply this to the whole pediatric patients. And we should actually look at modifiable intraoperative derangements such as hypotension, hypocapnia, hyperoxia or hypoxia, hypoglycemia, and hypothermia. Certainly, these are things that we can control and may actually increase the risk of perioperative neurological injury. When you look at this whole issue about neurodevelopmental outcomes, particularly after an operative period, there is an interplay between the environment, the patient's gene, as well as impact on the brain. And certainly any changes in the environment, such as surgery, the impact of prolonged hospitalization, the anesthetic drugs themselves, may change neuropsychology and impact the brain itself directly. Certainly, the environment can also impact the genetic makeup and the gene expression through epigenetics by modifying gene expression in these patients, leading to changes in brain development. And certainly the patients themselves may have some gene alterations that may be leading to neurodevelopment dysfunction. When you look at this issue, certainly this paper by Chris Homsey from our group at Harvard Medical School, as well as Boston Children's Hospital and their collaborators in the Pediatric Congenital Heart Consortium, you can see that there are commingling of mutations in patients with congenital heart disease that also lead to neurodevelopmental and other congenital anomalies. So certainly the fact that you have congenital heart disease increases your risk of gene expression of genes that may cause neurodevelopmental decrement. Also, neonates with non-cardiac congenital anomalies are at risk for brain injury. And this study by Soldwijk from Netherlands again showed that neonates and preemies who undergo surgery for non-cardiac congenital anomalies have an increased risk of brain lesions and brain injury after surgery in the post-operative period. However, the most devastating complication and outcome that we fear the most is the fact that perhaps we may be causing post-operative encephalopathy and due to inadvertent cerebral hyperperfusion. And in this case series by my colleagues, Dr. McCann, as well as Dr. Kalkman from the Netherlands, they reported 6 infants from 3 different centers, age 2.5 to 16 weeks, undergoing surgeries for a variety of neonatal lesions. What they noted was most of these surgeries were within 2 hours of length. However, they saw that their mean arterial pressures were somewhat low, 31 to 38 millimeters of mercury, and the anesthetic drugs are shown here. However, you can see the devastating impact of many of these neonates to develop neurological symptoms such as seizures and slow wake up due to completely after the surgery itself. And when my colleagues did a root cause analysis of these 6 patients, they found that their systolic blood pressures overall were much lower than the mean pressures that are seen in this patient population. Furthermore, they found that the end-tidal CO2s were much lower, leading to hypocarbia in these patients. So you can imagine the combination of hypotension and hypocarbia can lead to hyperperfusion. Certainly when we look at cerebral hyperperfusion, we do not know how low we can go. And this is an issue that has been a vexing problem that we as pediatric anesthesiologists have faced. When you look at the range of the lower limit of autoregulation in pediatric patients compared to adults, you can see that, as you would expect, pediatric patients have a lower limit of autoregulation. Therefore, they can tolerate lower blood pressures. However, when you see this whisker plot of the various patients that include, you can see a wide range of lower limits of autoregulation in the pediatric patients. So therefore, you can see that we're actually dealing with a very heterogeneous population of patients where we cannot predict what the ideal lower limit of autoregulation is, therefore, how low we can allow the blood pressure to drop. And certainly in premature neonates, you can see they have complete loss of autoregulation. And there's a study by Miles Suji from our institution showing you that there's no autoregulatory curve in these neonates during their various measuring periods in the neonatal intensive care unit. So therefore, we're dealing with a heterogeneous population of patients where their autoregulatory curve can be wide, can be steep, and can set anywhere and produce a wide degree of cerebral perfusion pressure. So how do we do this? Perhaps we should make sure that these patients are normotensive. However, in this study, again, looking at the group from the Mayo Clinic, the MASK studies, secondary analysis of the data showed that hypotension had no correlation with adverse neurodevelopmental outcomes that they found in their patient group. And when you look at data from the gas study, again, this is ad hoc reanalysis of the data comparing the patients who are in the regional group versus the patients who were in the sevoflurane group. You can see that the patients in the regional group had higher blood pressures overall. However, this had no impact to the fact that there were no differences in their various neurocognitive scores at 2 and 5 years. So therefore, the blood pressure itself may not be an adequate indicator of changes in neurodevelopmental outcome down the line. So what are some of the accepted techniques that are out there? Certainly many of us have used near-infrared spectroscopy to try to look at oxygen saturation in the cerebral tissue. And in this study by Daphne Michelet, published in Pediatric Anesthesia in 2015, you can see that drops in systolic blood pressures led to lower concentrations of cerebral oxygenation, and it was significant. And this was not related to peripheral saturations of pulse oximetry, end-tidal CO2, or sevoflurane. So there was a direct correlation between blood pressure and oxygen saturation. And certainly this may be an indicator, but in this study by Vanessa Albrecht and a multinational group of investigators looking at cerebral oxygenation during infant and neonatal anesthesia, you can see there's a wide range and incidence of cerebral desaturation in their patients. You can see that absolute desaturation down to 60% was about a 50% incidence. However, when the absolute ratio drop is greater than 50%, there's only an incidence of 2%, very low. The problem with this study is it did not look at neurodevelopmental outcome and behavioral outcome after the surgery, but it shows that oxygen desaturation down to 50% is indeed a rare event. When we look at our adult colleagues who use NIRS for perioperative monitoring for brain oxygenation, many of them have thought that perhaps it may be predictable of postoperative neurological stroke of neurological injury. You can see here that indeed their studies had very, very low confidence for postoperative neurological stroke or cognitive decline. And in this study, there was only adults were included as subjects. There were no pediatric studies. The only pediatric study that has been published thus far is by a group in Spain led by Gomez Pesquera, where they looked at negative postoperative behavioral changes as it relates to intraoperative cerebral oxygen saturation. And you can see here the risk factors that lead to negative postoperative behavioral changes are the long duration of surgery, preoperative anxiety, absolute decrease of the saturation itself. And this study was actually obtained data from parental assessments of their patients. Again, very similar to the child behavioral checklist, where the parents were able to determine changes in behavioral changes up to 7 days after surgery. So what can we do? Our group here at Boston Children's Hospital have been looking at various experimental technologies to look at brain perfusion during surgery. And we've adopted this NIRS-like device, which looks at frequency domain near-infrared spectroscopy, which utilizes 4 different spectra for looking at the NIRS, as well as the diffuse correlation spectroscopy to evaluate cerebral blood flow. And this diffuse correlation spectroscopy is very similar to the technology used for laser Doppler, which also provides an index of cerebral blood flow. And an application of this technology by our cardiac anesthesia group at Children's Hospital looked at the use of this combined FD NIRS as well as DCS you can see that they are able to show in patients undergoing cardiopulmonary bypass and deep circulatory arrest that oxygenation saturation increases during the bypass and normalizes post-bypass. You can see that they're able to measure cerebral blood volume similarly. They found that cerebral blood flow decreases during cardiopulmonary bypass and circulatory arrest and rises with reperfusion. They're also able to show that the CMRO2 decreases during cardiopulmonary bypass. Indeed, this is a way of looking at these variables in a non-invasive fashion. But what's more important is they're able to demonstrate the ratio of cerebral blood flow to CMRO2 in this fashion where when you get a drop in temperature, you have an increase in this ratio during the period of cardiopulmonary bypass and deep circulatory arrest, and then which normalizes with rewarming. In an ongoing study with our neuro anesthesia group, we've been able to apply this technology to patients undergoing PL syndrosis for Moyo-Moyo syndrome. And as you can see here, we've been able to correlate peripheral oxygen saturation, end-tidal CO2, and arterial CO2 with cerebral blood flow using this technology again. And at various stages of the anesthetic, you can see here induction, stapling of the drapes, the incision. You can see in the incision, there's a slight increase in cerebral blood flow. When we give propofol, you can see there's an increase in blood flow when it occurs. When the bone flap is out, you can see it normalizes, the arachnoid opening, closing, and as you emerge from the anesthetic itself, you can see that cerebral blood flow goes up. Very a nice way to be able to apply this in an experimental fashion, and hopefully this will lead to more conventional monitoring devices that we can use in the operating room. But let's think about what we actually do. And in this editorial that I wrote with my colleagues, Marcus Weiss, Bruno Bissonnette, and Thomas Engelhardt, we state that anesthetists rather than anesthetics are the threat to the baby's brain. And certainly we try to talk about the anesthetic drugs, the monitoring devices that we use, and perhaps they may be misleading us, but it is a poor workman who blames his tools. And certainly we should look to ourselves and see if we can improve our practice. And that basically goes back to the basics. In this initiative by our European colleagues, SafeTOTS, it was established to emphasize the role of a safe conduct anesthesia to prevent harm. And it looks at the 10 N's in pediatric anesthesia. And it's a checklist. No fear, no awareness, normal volemia, normal tension, normal heart rate, normoxia, normocapnia, normonatremia, normoglycemia, normothermia, and no postoperative discomfort. Again, these are things that we can do tomorrow and without any of this fancy equipment, and will improve outcome in our patients in general. And we also have to look at our patients, and certainly we are fortunate enough to have resilient patients where no matter what occurs during surgery and anesthesia, if there's positive and negative experiences during the procedure itself, the resilient patient will always come out normal. However, we have to worry about the vulnerable patients where perhaps they may have neurological injury due to changes in the environment as well as exposure to the anesthetics or the surgery itself. And certainly these patients who are prone to this are those certainly with congenital anomalies as well as prematurity. And also the impact of prolonged surgery and anesthesia and hospitalization itself can also lead to a negative impact, leading the vulnerable patient to have a bad neurological outcome. So neuroscience has shown us throughout development that there are various microscopic and cellular changes such as genesis of neurons, glia, dendrite outgrowth, synapse formation and myelinations, as well as pruning of these excess neurons and elimination of synapse and eliminations throughout the lifespan. And certainly anesthetic drugs, surgery, adverse events such as hypoxia can lead to changes in this process. However, we should also note that it's at the stage during the lifespan that may have an impact on various domains, such as negative environment during infancy may lead to sensory changes. During toddlerhood and adolescence, motor and language, and as well as our older patients, our teenagers, it may impact their higher cognition. So we have to address this whole issue of when these patients are impacted by these various environmental changes, as well as what domains we should be measuring throughout the lifespan of the patient to see what the true neurodevelopmental impact of our interventions are. So going back to Andrew Davison and Laszlo Vutskit's editorial, I have to agree that thus far there is no coherent phenome for an association between anesthesia and surgery and adverse neurodevelopmental effects. And certainly this is something that we should keep in mind, that we should continue to anesthetize our patients using our basic knowledge of how we manage these patients, and also keep our eyes open for any changes that may lead to improvements in our care of these patients. Thank you very much again, and I hope to join you in person at the next meeting, hopefully in 2022. Thank you again for your attention.
Hello.
Oh, great. Thank you very much. And as far as the technological problems, as an educator, I must say repetition is key in learning new knowledge. So I think it's perfect, and I look forward to hearing some of your, listening to some of your questions, and also trying to address some of the issues that may not be fully covered in the talk. Furthermore, I hear that the organizers are going to do a rebroadcast of this for the delegates, so you'll get a smoother presentation and a more complete presentation.
Absolutely. Thank you, Saul, for really a very enlightening lecture. And to our audiences, we thank you for your patience. And as Saul has mentioned, this lecture will be available on our website, so you can review it later on at your leisure. And Saul, we really appreciate you sharing your insights on how to look after our patients in the operating room to minimize the risk of neurologic injury. And I'm sure this will no doubt have a great impact on how we manage our patients here. So we actually have quite a lot of questions from the floor, so we will try to attempt to address most of them if we can. So we have a question from Dr. Teddy Fabilla asking that, Prof, would it be fair to say that the current state of evidence in the clinical studies has shown that one single GA really has, that there's no evidence that it's harmful to the developing brain apart from parental reported behavior. So a single GA is not harmful to neurodevelopment other than what the parents perceive. What do you think?
Well, my biased opinion would be, yes, I feel pretty confident a short exposure to anesthetic, less than an hour, will lead to no changes in the Bailey's exam and the Wechsler exam 5 years later. But as you know, as we've gotten more sophisticated measuring techniques and metrics for looking at neurodevelopmental outcomes in patients, further on, such as the MASK study has shown some changes in some of these patients using these fine assessments of motor skills, as well as speed, reaction times, and also the group in Avon reported some pinpointing and balance issues with some of their patients. We may see a lot of these studies coming up, but I think for the major metrics for looking at neurodevelopment, the standard scores, scales, I don't think we'll see any more changes with that. But as we become more sophisticated, that's why I said we had to open our eyes. Perhaps we may be impacting some domain that's still not yet discovered and proven relevant in development.
Right. Thank you. And in relation to that, we have Prof. Alan Finley actually mentioning that it's really a comment that the studies that showed learning disabilities after early general anesthesias contain significant proportion of patients for ENT procedures, probably mostly like laryngotomies, right? So an important factor is delayed language development with impaired learning. subsequent to that. So he suspects that most of those results demonstrated the association more due to the disease rather than causation due to general anesthesia. And in relation to that, we have another Dr. Zara Sepil-Olsen, who basically mentioned that she's still confused with how we can differentiate the effects of hospitalization, fluids, the surgical issues, right, as being the cause of neurodevelopmental delay rather than the general anesthesia itself. So how would you then possibly tease out the potential differences?
Well, I agree with Alan. Certainly, in my last slide, looking at the various stages of development, early on, if you impact some of the sensory development for toddlers, for instance, most of them are undergoing myringotomy tubes for chronic otitis media. Certainly, they're at risk for developing language disorders, and that's been shown by some of the studies in Canada. Ruth Graham's study from Manitoba exhibits that, where she showed that some of the kids who underwent oral laryngology surgeries, particularly for ear tube placements and tongue ties as well, had lower scores, and that was in the domains of language and understanding. So there's no doubt that has an impact, but who knows whether or not it's because they're delayed from the disease process itself or the anesthetic exposure. But I imagine it will be the former, it's the disease process itself. And the second observation by our astute delegate, certainly there are a lot of factors and confounding variables, and you see that with any clinical setting. And that's what makes clinical investigations interesting, is try to be able to tease out the confounding factors to see what actually causes what is the cause and effect. For myself as a basic scientist, it's easy because I control all the variables and just look at one intervention and one effect. But it's much more difficult with clinical studies, and that's something that's being ongoing. And again, as our tools or measurements become more refined, we'll see more changes. And whether or not that's clinically relevant, it's up to the reader as well as the practitioners to decide.
That's great. Thank you, Saul. And the next, we actually have a few questions that kind of related. Okay, and I'll just read out one of them.
Sure.
And it's regarding the blood pressure control, right? With such variation in cerebral autoregulation, as you've shown very nicely on your slides for neonates, that really, there's no set definite range. So what is the lowest blood pressure that you would be prepared to accept? What is the safe blood pressure that you can go lowest during surgery, which is age appropriate? And does it differ for different kinds of surgery?
Well, the one that will allow them to wake up without neurodevelopmental.
Yeah. What's the magic number?
Because as you well know, we've been there in the neonatal, taking care of neonatal patients who had necrotizing enterocolitis, and you can imagine some of those low blood pressures. You and I have taken care of those when you were in Boston, and you'd be surprised how they came out of it. Sometimes they had no blood pressure, so it's tough to see to understand what is the right pressure. Fortunately, those patients came out unscathed by being exposed to those low blood pressures. But if you also look at that multinational study looking at NEERS, the first author is Vanessa Albrecht, you can see that the incidence of cerebral desaturation is only 2%. That's cerebral desaturation down to 50%. And in their study, they didn't see any acute neurological deteriorations in that patient. So it's a rare event, and we're not sure which patients will develop significant postoperative stroke. But again, what tempers that is the fact that we still get a scattering of cases, such as the one reported by Mary Ellen McCann, where you had those 6 patients who we thought flew right through their surgeries, but had these devastating neurological injuries that occurred intraoperatively. So that's why we have to remain vigilant and try to maintain homeostasis as much as we can under these really trying conditions, certain blood loss, hypoxia, and such.
Yeah. So what do you think is the role of NEERS in the routine care of neonates, right? Would you recommend that, all neonates should have a NEERS monitor or?
Well, it depends on how you use it. Certainly, our cardiac colleagues have been using it much more than we have. In fact, NIRS has been applied to on the flank to look at systemic oxygenation. George Hoffman at Medical College of Wisconsin has published some nice papers where they used the NIRS and applied it over the trunk to see what perfusion is. I think he told me indirectly he wants to see what renal perfusion is during these surgeries, and he claims that it may improve perfusion. But as noted though from that multinational study by Albrecht, you really can't. It's not definitive. It's a nice thing to have, but again, like the pulse oximeter, it may give you some relief that you are oxygenating the patient, but whether or not that changes outcome, the jury is still out.
Yeah. And on that note, when we're talking about NIRS, what do you think is the role of EEG monitoring in young children? Not necessarily neonates, because it might be a little bit hard, right, to put in a small sense. Do you routinely use EEG monitoring in children? Do you think it's helpful?
Well, I think my dear friend and colleague Patrick Burden will probably be more expert in addressing that tomorrow. But we use EEG for our Moya patients to see if there's any signs of ischemia. And if indeed we see patterns of ischemia during the surgery itself, we do have some interventions, such as giving a small dose of propofol to balance the supply and demand, as well as increase the blood pressure and give fluids to really to optimize perfusion. But again, we published a study showing that it really didn't predict postoperative strokes. And I challenge anyone to be able to demonstrate that EEG will prevent postoperative strokes, unless in the setting probably of carotid endarterectomies. But the jury's still out on that as well for our adult colleagues. So it's nice to be able to provide some relief that we are looking, but whether or not we're looking at the right thing and whether or not the changes are clinically relevant, again, is still undecided.
Sure. Okay, understand that. Okay, we have another question. In fact, we have quite a few, so which is great. A question, this is from one of the audience. The question I always get from parents of neonates is, isn't sedation better than a GA, safer than a GA? Is there evidence to support or refute this claim from a neurobehavioral outcome perspective?
Well, I think sedation is safer because that means you're not really providing any significant drug that will cause respiratory depression or hypotension. Certainly when you induce anesthesia, you put the patient at risk for losing the airway, and the Nectar study as well as the Apricot study from Europe shows that some of the morbidity and mortality occurs really from respiratory and cardiovascular collapse during the intraoperative phase. So general anesthetics certainly can produce that. So sedation, if done correctly, is probably safer in good hands. The problem we're having here in the United States is we're having the issue of single operator sedation. That is, where the procedurists themselves are providing the sedation while they're pulling a tooth out in a dental clinic, for instance. And there have been scattering of devastating neurological and, in fact, deaths in some of these patients who've undergone procedural sedation while the procedures itself is doing the surgery or procedure and sedation at the same time. So sedation, I think, is much safer, and it's certainly something that I feel comfortable with.
Great. And on that note, does it matter what you sedate them with? How safe is ketamine, for example, for neonates in pediatrics versus, say, propofol or the other drugs, midazolam?
I think if used judiciously, they're all safe drugs. When you think about the fact that these drugs have been around for years, and we've had good effects, the only time is when we've given overdoses. They're all safe drugs, and you just have to look at the qualities themselves to see what's best. Certainly for kids who you want to have spontaneously ventilating, ketamine is a great drug if used cautiously and not giving us an overdose. Propofol is great because it induces sedation rapidly, but again, you can have that period of hypotension after a dose of propofol. We've been using a lot of dexmedetomidine because in my own lab, we've been able to show it's neuroprotective, but there's a long lag time for its residual sedative effects to wear off. So each drug has its pros and cons, and as a clinician, it's up to you to be able to decide which works well with these patients.
That's great to know. I love your slide, the smart thought slide with the 10 N's, right? It's what you do, it's not what drugs you use. So I think that's a good reminder for all of us.
Yeah.
I think we have time for one more question, which is...
I hope it's an easy one.
It will be easy for you. Is there any evidence of hyperglycemia having an impact on neurodevelopmental outcome?
I mean, that's a classic issue that comes in the adult literature, adult ICU literature. Mm-hmm. However, I haven't seen much in the pediatric literature because obviously the neonates aren't able to liberate glycogen as efficiently as some of the older patients. So to play it safe, I think it's better that these patients be a little on the sweeter side, as I would tell my trainees, than obviously not being hypoglycemic. So I tend to be able to provide some glucose during these procedures, and certainly the ones you have to worry about are the chronically ill patients where perhaps a high neuroaxial block may actually blunt the sympathetic response to the surgery, and they won't be able to release glucose. So those are some of the other patients that may be at risk for hypoglycemia. So hypoglycemia is better than hypoglycemia, certainly in our pediatric patients.
We have to choose one, right? Yeah. But ideally, normal glycemia.
Exactly.
Yeah, absolutely. Well, thank you very much, Saul, for this most enlightening session. I'm sure, I really enjoyed it. And really thank you for your patience and taking the time to share with your expertise with our audience.
Well, certainly an honor to be reunited with all of you and be able to talk about some of the things we do here back in Boston and among my colleagues here in the U.S. And I look forward again to be able to see you soon in person. And thank you again for your fantastic questions and your interest in this topic.
Thank you. Saul, this is the time that, normally we'll give you like a thunderous applause, but this being virtual, so just accept our virtual applause. Okay.
Okay.
Thank you so much.
Thank you.
And now, after this enlightening session, I would ask us all to prepare for another exciting plenary lecture. I would like to introduce my colleague, Dr. Angela Yeo, who's the director of our Children's Pain Service, who will introduce our next speaker. Angela.
Thanks very much, Chen Lei. Okay, excellent. Welcome, everybody. I guess most of you would have really enjoyed that first plenary. Now, it is my privilege and honor to introduce our next plenary speaker. Now, Prof. Ellen Finley. Prof. Ellen Finley is a pediatric anesthesiologist who has worked for more than 30 years in pain research and management. He is professor of anesthesia, pain management, and perioperative medicine at Dalhousie University and is cross-appointed as professor of psychology and neuroscience. He also holds the inaugural Dr. Stuart Winning Chair in Pediatric Pain Management at the IWK Health Center in Halifax and is director of the Center for Pediatric Pain Research. He has also published over 130 papers in peer-reviewed journals and has lectured widely with more than 300 invited presentations on 6 continents. Prof has also started the Pediatric Pain email discussion list, and that was in 1993. And that brought together pain researchers and clinicians from over 40 countries. His own research and educational projects have taken him to Jordan, Brazil, Thailand, China, and elsewhere. Prof. Finley's main interest is in pain service development and advocacy for improved pain care for children around the world. And to facilitate that, he is co-founder and board chair of the Childkind International initiative. So, Prof, we are really looking forward to your plenary speech on advances in perioperative pediatric pain management.
Well, good morning. Thank you very much for that kind introduction. And I'll say Sawadee Krap to my friends in Thailand, and Namaste, Ni Hao, Ohayo gozaimasu, and then I've run out of languages. I've been asked to talk to you about advances in pediatric perioperative pain management. And I really appreciate the honor of being invited to speak. I really also wish I could be there with you. I don't have any relevant conflicts of interest, except I do find that work is starting to interfere with golf to an excessive extent. One of my friends and colleagues, John Muir, used to say that it's a serious mistake to treat children like small adults. However, it's often quite appropriate to treat adults like big children. So some of the information we work with in children's pain management comes from adult research, but much of the many of the ways that we approach patients probably should be taken back to the adult world as well. So for those of you who do both, this should be applicable everywhere. Now, just a couple of basic principles that you're probably all aware of. Pain is there to warn us of danger. It's to tell us when something is ripped or torn or broken. This young boy in this 18th century painting is going to be arriving in the emergency department in about 20 minutes with his supracondylar fracture. Chronic pain, as you know, continues after the tissue injury is over, but post-surgical chronic pain is a real thing, and therefore this plays a role in what we're talking about today as well. Last year, the International Association for the Study of Pain issued a new definition for pain, which was actually not that different from the previous one, but with a few refinements. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So we talk about burning pain even though nothing's on fire. That's resembling potential tissue damage. The last note on that slide is the one that's relevant to pediatric practice, making it clear that just because you can't complain about pain or describe it doesn't mean you're not feeling it if you're too young or cognitively or neurologically unable. The other interesting changes that IASP disseminated a couple of years before were this new categorization of pain. We're all familiar with nociceptive pain that comes from tissue injury, mechanical or inflammatory tissue damage. Neuropathic pain as well is a specific damage to the nervous system. Nociplastic pain is pain resembling nociception, but not resulting from actual tissue damage. And so it's really a dysfunction of the nervous system. Conditions like fibromyalgia, visceral hyperalgesia, and others could certainly fit into that category of nociplastic pain. But they're important because if you are dealing with acute or surgical pain in somebody who has pre-existing peripheral or central sensitization and wind-up and nociplastic pain, then managing the acute pain is going to be that much worse. John Benica, an anesthesiologist in Seattle, Washington, was the founder of IASP. And in 1990, he said, "For nearly 30 years, I've studied the reasons for inadequate management of postoperative pain, and they remain inadequate or improper application of available information. In other words, not using the information we have already is one of the most important causes of untreated pain. Now, this lecture isn't going to give you drug doses or specific techniques. There are other much more capable people in the program later today and tomorrow who will be touching on some of these issues. But I thought I'd give a bit of an historical overview, partly personal and partly from others. I've been privileged to really be involved in the pediatric pain world almost from the beginning of people's recognition of it. So I've had a pretty interesting career and been very privileged. We've had over 3 decades of pediatric pain research. We have an increased understanding of developmental neurobiology of pain. We understand that there are short and long-term consequences of inadequately treated pain, and particularly this is important in the developing brain, in children and infants, and particularly newborns and premature babies. We understand that there are multifactorial aspects of pain and that we need a multidisciplinary team to help to solve it. None of us have all the skills required. And we've developed ways to assess and treat the majority of pain problems in children regardless of their age and cognitive ability. So it's pretty exciting. You would think we had an answer to all the problems. Lena Case did a bibliometric study a number of years ago which showed an incredible growth in published pediatric pain research from 1975 to 2010, an almost exponential rise in the number of peer-reviewed articles. And one has to assume that this has continued to grow. Nevertheless, there are multiple reports of persistent significant pain prevalence from many different countries of children in hospital. Moderate to severe pain, often not treated adequately, and this persists to this day. So we really need to work harder to make a change. I love this slide from my friend Neil Schechter. Just because we know something doesn't mean we're going to do it. So how about looking a bit more further back in history? One of the fascinating things is that is this quotation from Voort in 1656, who said, "If a new skin in old people be tender, what is it you think in a newborn babe? Doth a small thing pain you so much in a finger? How painful is it then to a child, which hath but a tender new grown flesh? If such a perfect child is tormented so soon, what shall we think of a child which stayed not in the womb its full time? Surely it is twice worse with him." So Voort actually understood that children and infants could have more pain from an injury than an older person or an adult, and that premature babies were particularly sensitive. And yet somehow this concept was lost for many years. Now there have been some more recent milestones. First, the most infamous one, Swafford and Allen in 1968, publishing a statement that said that pediatric patients seldom need medication for the relief of pain after general surgery because they tolerate discomfort well. That's kind of horrifying to hear for people like us. Eland and Anderson and then Neil Schechter published iconic articles demonstrating the differences between pain care after surgery for adults and children and demonstrating the discrepancies. A particularly momentous event was that of Jeffrey Lawson, a newborn who had cardiac surgery without any analgesia in Washington, D.C. His mother, after he died, shortly after surgery, his mother recovered his anesthetic records and was horrified to see that he had not received any pain medication at all. So she complained to the anesthesia department and then to the hospital medical staff committee, and then to the licensing regulatory board of the region, none of whom were at all helpful. So then she complained to the Washington Post newspaper, and that created quite an uproar, which really was a turning point in the public understanding of what physicians and healthcare staff were doing or not doing in the care of infants. Sonny Anand and Paul Hickey did, again, landmark studies looking at outcomes of cardiac surgery and other major surgery in neonates, and identified that not providing opioids for pain management resulted in a higher morbidity and mortality. Again, the fascinating thing there is that this reached the public, and as the study was being done in the UK, the House of Lords, and Sonny Anand was attacked almost for doing these experiments and not giving babies morphine for pain. Whereas, of course, the actual experiment was to give them morphine, and normal practice was to give them nothing. So quite an eventful time and a fascinating set of events. In 1987, also Patrick McGrath and his wife Anita Unruh published the first textbook ever on children's pain. This is my copy, which, as you can see, has been very well used and frequently read, perhaps a little abused. So, why is children's pain ignored? Isn't there a basic parental need to protect children from suffering? Studies have shown that parents expect their child's pain to be relieved. And the greatest distress for parents is failing to protect their child from suffering. Any of you who are parents know this very well. And actually, I think it's always worse for those of us in the profession, because it's our job to protect patients from suffering. And if we can't do that for our own children, it's even more stressful. The other interesting thing, as I alluded to before, is that the public has assumed that if we're not managing pain, it's because we can't, because we're unable to, that we're obviously doing everything we can to prevent and treat pain. And you and I know that that is just not true. So why is it important? Well, clearly, we're in this business for humanitarian reasons. We're there because we want to help people. We also know that acute pain is a key risk factor for chronic pain. Failure to manage acute pain affects recovery time, hospital stay, and therefore economic costs, both to the healthcare system and to the family. From a very pragmatic point of view, if a child is hurt when they come to the hospital, how are they going to feel the next time they have to go to the hospital? And how is their attitude towards healthcare in general going to develop? And finally, it's hugely rewarding to relieve pain. I'll throw in a short personal story here. 8 or 10 years ago, I was feeling very frustrated and discouraged because I couldn't get the support from the hospital for the pain clinic and the things we wanted to do. And I was saying to myself, I need to just give this up. I can't keep going. And I walked into the office of our clinical nurse specialist, and she said, "Hey, Alan, that young boy you put on a ketamine infusion this morning, he's doing fantastically. He feels great." And then I realized I couldn't quit. So every day, every time I'm on service, something happens to make me feel really good about what I'm doing. And I'm sure it's the same for many of you. So let's go back to do some more ancient history. I finished my residency in 1985. I was at University of Toronto, and so I had 2 6-month rotations at the hospital for sick kids. At that time, postoperative pain management was really solely under the control of the surgeon. Once patients left recovery room, anesthesia had almost nothing to do with them. Surgeons and nursing staff had little understanding of pharmacokinetics, use of consistent dosing, and there was a great fear of analgesics and their side effects. There weren't any continuous opioid techniques in use. There were no postoperative regional techniques, and really very few intraoperative regional techniques. As I mentioned before, I've had a really cool career. It's been an amazing time to be in this business. Over my period in anesthesia, we've seen development of pain assessment, many different tools and techniques, but regular reporting as a standard of care, and that has been transformational. We understand to use paracetamol and non-steroidal anti-inflammatory drugs on a regular scheduled basis rather than as necessary. We started using continuous infusions of opioids and regular oral dosing and patient-controlled analgesia. We've taught surgeons that they can put local anesthetic into the wound, and that actually helps the child wake up more comfortably. We've learned how to use caudal blocks and other simple blocks. We use low-dose ketamine infusions as an adjunct in many children, particularly those who've had multiple previous surgeries or a visceral inflammatory disease like ulcerative colitis or pancreatitis, or those who've had chemotherapy, anything that might sensitize the nervous system to pain signals. And we've developed pediatric acute pain services that not only provide specialized techniques, but individualized care for individual patients, not just recipes. And that, I think, has been transformational as well. We've got some new drugs and drug applications, although surprisingly few when you think about it. My younger colleagues would suggest that TIVA, total intravenous anesthesia, helps patients wake up more comfortably and feel better, which may or may not be true. Gabapentin or pregabalin as pre and post-op treatments to reduce nerve sensitization. Alpha-2 agonists like clonidine and dexmedetomidine are probably going to have valuable roles in perioperative care. Intraoperative steroids for procedures like tonsillectomy not only reduce nausea and vomiting, but actually have been shown to reduce postoperative pain and opioid requirements, presumably from reduction of inflammation. But it's really important to remember that you don't have to have complex, expensive techniques or fancy pumps to provide good pain care for the majority of patients. There's lots of simple things we can do. And as I often say, it's all very well to think about how you're going to develop a program over the next 5 years, but you should also be thinking about what you can change next Tuesday, because that can often make the biggest change in the culture and the practice. We've had the development of regional anesthesia and analgesia, epidural analgesia continued postoperatively as a routine tool. The use of ultrasound. Quite a few years ago when we were considering getting an ultrasound machine for our department and our operating room for central lines and blocks. I asked the chief of radiology what he thought about this, thinking that he might feel we were infringing on his territory. And he looked at me and he said, "Why would you put a needle somewhere you couldn't see?" And even though we've been doing that for a century, I didn't really have a good answer for him. So now the younger generation of anesthesiologists are all learning these techniques, are using ultrasound like it's a third eye, and making tremendous use of the technology. Different types of peripheral blocks are taking over from some of the neuraxial approaches. Simple field blocks, tap blocks, paravertebral blocks done either by the anesthetist or by the surgeon during a thoracotomy, for example, and others more localized fascia and plane blocks for thoracic and abdominal surgery. Our cardiac anesthesiologists are using these now every week for post-op pain care. Now, one of the interesting things is that many of these advances have been driven by the so-called opioid epidemic, at least in North America. And which raises the question, do we need to eliminate opioid use in anesthesia? I think most of us would say we can't. Opioids are certainly indispensable. But to be honest, we also probably would have to say we could be using a lot less opioids than we did in the past. I do not believe that intraoperative opioid use contributes to long-term opioid use disorder. However, when opioids are used as the sole agent for postoperative pain, then there is a problem because they ignore the neuropathic and nociplastic mechanisms of pain. And anybody after surgery who's got pain continuing for weeks or months needs a different approach than just giving them more opioid drugs because the pain mechanism is undoubtedly not responsive to opioids. There have been approaches to physical techniques like circulating cold blankets for hip and knee surgery. Particularly popular fad these days is ARAS, the Enhanced Recovery After Surgery technique, which was first developed for adult gastrointestinal surgery and has broadened from there. We're taking an approach to it with our scoliosis procedures. This is actually pretty great because it really brings surgeon and anesthesia and other disciplines together to provide a comprehensive approach to patient care, including patient and family education, psychological preparation, physical preparation, fluids and calories pre-op, early oral nutrition post-op, and importantly, pain prevention and treatment, preoperatively, intraoperatively, and postoperatively. And all of this improves recovery profiles, we believe, and has great potential to be developed further. There's even this ARAS Society, the website's there, which has a vast number of guidelines, although most of them for adults. There is one for neonatal gastrointestinal surgery developed by Mary Brindle from the University of Calgary in Canada, describing the preoperative, intraoperative, and postoperative care. Team communication being the highlighted most important aspect of it, but I'll also draw your attention to the bottom right where it talks about parental involvement, early hands-on care by parents, and partnerships and communication. Equally, there are guidelines being developed by many different organizations. This one's from the European Society. Um, and we can't go through all of those today, but they're easy enough to find, and you need to pick and choose and decide which components are suitable for your situation and your resources. So what can we do? It's a problem. A number of years ago, I wrote a little commentary, and in it I commented that I saw 4 different components of pain services that hospitals needed to develop. Now, in some cases, they don't develop in this order, but I think the most important one is actually number 1. We have to have a system-wide approach to pain prevention and treatment that all clinicians are invested in and knowledgeable and skilled at. This includes non-pharmacological management, procedure pain prevention using topical anesthetics and distraction, proper use of paracetamol and even simple oral opioids. Families need to understand this, and all nurses and all physicians and physiotherapists and psychologists and other clinical care providers need to understand this. And this can go a long way to improving the total burden of pain on children in the hospital. The second piece that many of us are familiar with is developing the specialty acute pain service, as I talked about before, which provides expertise for regional techniques, PCA, complex patients with neurological or respiratory disease, or neonates, or just patients with previous pain experience that need really focused and specialized care. But the care has to be individualized, as I mentioned, not just based on a recipe that people look up in a book. What's going to happen in the future? We would hope to see enhancements in regional techniques, so more refined and precise nerve blocks and better control of duration and intensity of the block. Long-acting local anesthetics, liposome-bound molecules and so forth have been described. They sounded like the answer to the problem, but in fact, I haven't been impressed that the data has shown them to be dramatically valuable. Enhanced non-pharmacological approaches, routine psychological preparation is very important. We use guided motor imagery and mirror therapy for treatment of unilateral chronic pain conditions like amputation and CRPS, complex regional pain syndrome, and so forth. Should this be used in preparation for unilateral surgery, not just when a chronic pain problem develops? Virtual and augmented reality certainly are techniques that can be helpful for helping children manage pain, particularly acute or procedural pain. Individualized medicine, pharmacogenetics. Wouldn't it be great if every patient came with a list of which drugs were most effective and in what doses for their individual biology? And hopefully our surgical colleagues will be developing further techniques that cause less pain. Again, we all know that some surgeons' patients have a lot more pain after the operation than other surgeons, presumably related to technique and gentleness. Not all minimally invasive surgery is less painful, but much of it is. And obviously there's a long way to go there in developing further techniques. How about the research questions? We need to learn more about the mechanisms of acute and chronic pain? What are the predisposing and preventative factors? What are the triggers for prolonged and chronic pain? Which of these are the neuropathic and nociplastic components of pain, not just those related to tissue injury? And how can we target interventions at those specific components? How about the self-management issue, preparation for surgery? Children are being sent home after surgery much more quickly than they were in early years, which means a lot of pain management is being done at home by the patient or by their parents. Mobile and electronic health applications are being developed right, left, and center. Relatively few of them have had good research done to see whether they're effective or how they should best be used, but some of them have. And there's a tremendous room for that as we all know, children and teenagers are increasingly embedded in electronic devices and applications. Health systems research to look at the economic outcomes from changes such as ARAS when it's applied, and long-term follow-up the patients from these practice changes to see whether there's really a benefit to them and not just to the system and the costs. Chris Eccleston led a really impressive group of clinicians and researchers to write the Lancet Commission on Pediatric Pain, published in Lancet Child and Adolescent Health last year. And I'd strongly recommend that everybody look at that. They did identify 4 specific priorities that we needed to make pain matter, and that equity and accessibility needed to be addressed. We need to make pain better understood, particularly the mechanisms contributing to variable responses to pain and injury and pain treatment. We need to continue to make pain visible. We need to assess and measure it and make sure that our approaches are child-centered and family-centered. And of course, we need to make pain better. We need to improve existing treatments. We need to develop new approaches. From my point of view, the most important goals are to develop a culture in every hospital for pain prevention and pain treatment, just the same way as we have a culture of infection control and washing hands. This applies to all disciplines in healthcare and all levels of all discipline. You can't expect the ward nurses to manage this all by themselves if they're not supported by their managers and by physicians and surgeons and hospital administrators. And ultimately, this moves to the political level and government accountability. We need preventable pain to be a reportable adverse event, just like a central line infection or falling out of bed and breaking your hip would be a reportable adverse event. This isn't to blame individual staff members, but to develop a systems approach to correcting the deficits. We need to use the knowledge we already have. So I think we know what to do. And what I'll do is leave you with these resources that I've been involved with. There include ways to help promote pain prevention, educate clinicians, educate families, and to network and share ideas. And with that, I will say thank you very much. It's been a great pleasure, and I'd be happy to answer any questions, and even happier to come and do it in person sometime soon.
Thank you very much, Prof. Finley. That was an excellent, excellent talk. It's really such a great honor to have you with us, and very, very great. We're very grateful that you're so willing to share your knowledge with us at 10 p.m. at night on your time. And I think there were a few components of your talk that were really that really kind of resonated with me, and I think with the audience as well. That picture that you had of knowing is not the same as doing, that really resonates with me, because I take the lift at work instead of the stairs. So well, I must say, yes, I agree. We have come such a great way since 1968 and then 1986, particularly in the Jeffrey Lawson's case. And I think most of our audience will probably not be aware that back in that time, it was the norm to just not provide any analgesic for neonatal cardiac surgery. And while it seems very cruel to us now, I think his mother did a great job of bringing attention to it. And it's really excellent that with all the work that pediatric pain researchers and pediatric pain physicians are doing, we are bringing awareness to the masses that in general, it seems that up to 25% of children are in moderate to severe pain in the post-operative period. And really, this shouldn't be the case if we can help it. So I think your idea of making preventable pain a reportable adverse sort of event, it is really an idea to for people to consider bringing to their hospitals. Can I just find out from you, Prof? So we've got a few questions on the chat, and I'd like to address some of them first. We had a question from Dr. Teddy Fabela, and he says, "Good morning, Prof. Ellen. What is your take on strict versus pro-rata opioids following surgery in order to avoid analgesic gaps? Currently, there are some divided opinions with regards to prescribing opioids strictly, factoring in all the opioid side effects, dependence, and safety. Do you have an opinion on that, Prof?"
Sure. It always depends on the situation, on the type of surgery, the risk for significant pain based on the patient's prior experience, and many other factors. Absolutely, we should be starting with the non-opioid techniques. So we should be using local anesthetic wherever we can, whether it's infiltration or field block or regional block or whatever. We should be using paracetamol in everybody on a regular scheduled basis, at least initially. Probably the same for anti-inflammatory agents if there's no contraindication. Once you have those in place, then the question is, how is the patient going to do from there? If you feel that the procedure is minor, the risk of pain is minor, you expect the patient to do well just with those techniques, then a small PRN dose of opioid makes sense as long as you're monitoring that. Now, one of the things that drives me crazy, and I've been campaigning against for 20 years, is the idea that 4 hours is the minimum interval between opioid doses. In fact, 4 hours is the maximum interval between doses if you're trying to create a steady state with a regular dose. What should the minimum interval be? The minimum interval is based on how long it takes the medication to be absorbed, distributed, have a pharmacodynamic effect, and be recognized by the patient. So if you're giving small intravenous doses, such as from a PCA pump, the interval might be 5 or 6 minutes, because that's how long it takes an intravenous dose to reach the brain and be distributed and have an effect and be noticed. You don't want somebody pressing it 3 times in 30 seconds. If you're giving the drug orally, what's the minimum time? Well, probably 45 minutes or an hour. So if we write a PRN dose for an oral opioid, in my world, the interval should be every hour if needed. But the dose should be small enough that that's reasonable. And so that's a way of adjusting it. And then you want to see whether, in fact, they're requiring frequent doses. If they are needing a dose every hour of an oral opioid, then probably they need a regular scheduled 4-hourly dose to establish a steady state. And that's the mistake that I think people make sometimes, is they give a fixed large dose, and obviously that's not optimal. The problem is it requires attention and monitoring and decision making as things progress, not just following a recipe. If it's a big deal, big surgery, high risk of pain, then yeah, you might start with a continuous infusion or a regular 4-hourly oral dose with an hourly breakthrough dose in between. So again, so you can adjust the amount.
Right, right. Thanks very much, Prof, for that. And what about gabapentin? Because, recently gabapentin's been trending up and down in the past decade. And Dr. Sumin Lee has asked, what is the current best practice for pediatric perioperative use of gabapentin?
Well, we still believe in it. We feel it's valuable for any surgery in a patient who's been previously sensitized, either by multiple surgeries or pain events or chemotherapy or something like that, or in any surgery where nerves are going to be abused and stretched and pulled out of, their normal state, like, for example, scoliosis surgery. And so all of those patients get preoperative gabapentin, which is then continued for some weeks afterwards.
Right. Okay.
In our practice. One of the problems always has been that studies of neuropathic pain drugs like gabapentin have been done on populations without our ability to identify the actual mechanism of the pain. So my example for that is asking you, what is the correct dose of penicillin for fever? And the answer is, well, it depends. And if the fever is due to a bacterial infection that's sensitive to penicillin, then there's a dose. If it's due to a virus or heat stroke or malignant hyperthermia or hyperthyroidism, then penicillin isn't going to do anything. So studies have been done on gabapentin that are the equivalent of looking at penicillin for fever. And so we don't have a good answer because we don't have a way of saying what is the actual mechanism of this patient's pain right now. And will it respond to this drug or that drug or no drug? So, but we like gabapentin because it's pretty safe and side effects are pretty well understood, and it seems to help quite a few of our patients.
Ah, excellent. Prof, so Dr. Bangchun Lei has put in a question. She says, thank you, Prof, for an excellent lecture. And I guess this also ties in. What do you think are, maybe apart from gabapentin, what are the specific strategies in acute pain management which have been proven to reduce the development of chronic pain?
We know that failure to treat acute pain is a risk factor for chronic pain, no question about that. There's has been quite a lot of research in adults on predictive factors, really not very much on kids. I think the best we've got right now is do everything we can to alleviate preoperative pain. Because if you operate on a patient, particularly on the area of the patient that is sensitized, then it's just going to wind everything up to an even greater extent. Every time I go to a major pain conference, the basic scientists talk about some new aspect of glial cells or nerve connections that that have an impact, and I understand it perfectly for about 10 minutes, and then I don't understand it anymore. So there's a lot of work to do. I think from our basic practical clinical perspective, all we can do is try and reduce the pain as much as possible beforehand, try and reduce the stimuli as best we can. Again, regional or local anesthesia is perceived to be a good approach for preventing sensitization. But I think one of the most important things is to have a mechanism to jump in if the pain is persisting after surgery and not let it go on for months and months and years, which means collaborating with our surgical colleagues and making sure they call us when the patient comes back to the surgery clinic 2 months after surgery and still has severe pain, that they don't just give them another dose of morphine to take home, but they let us know and let us get involved. Because if we can capture it at 2 months, it's so much easier than if we're asked to do it at 2 years.
Agreed. So we really don't want it to become a chronic problem without our know-how, without us knowing.
That collaboration and communication that really makes the difference.
Right. And this would also kind of partially answer Dr. Karis Ku's question. She's actually asking about your approach to getting surgeon buy-in, so to speak, for analgesic prescriptions. What has your kind of approach or technique been when working with your surgeons? And her second question is also with regards to opioid use or in patients with PONV. What is your approach to managing sort of like the intractable nausea and vomiting in the perioperative period? So the two questions.
Yeah. For many years, my approach to managing pain in our orthopedics patients was based on the fact that the chief of orthopedics was older than me and would retire first. And in fact, when he retired, the care was transformed and patients were much more comfortable. I think, again, it's communication, it's understanding their concerns and their issues, helping them understand that good pain care is going to make their patients happier, help them go home sooner, help them have fewer complications, so it benefits them. But also listening when the orthopedic surgeon says, I'm really frightened of a compartment syndrome in this patient. I'm worried about doing a block because I'm afraid it might cover that up. And being willing to communicate and collaborate and say, okay, that's great. Let's see what we can do some other way for this patient. And if you establish that relationship, then you're much more likely to have them say, all right, let's see what we can do. Let's work out a care pathway that includes pain management, which is exactly what our spine surgeons have done with us. About 10 years ago, a new orthopedic surgeon was with me in the OR, and he said, "Oh, Alan, I'd really like to have a block on this patient. Could you try it again? Because it didn't. You were having a problem. Take all the time you want." And I nearly fell over because I couldn't believe a surgeon was saying that. So there are great ones coming along, but establishing that team relationship, establishing that collaboration, the willingness to reach out and help them when they need the help so that they're willing to communicate with us has been great. And that's what you have to do. The other question was about nausea. Again, as I mentioned, my younger colleagues would insist that TIVA reduces post-op nausea compared to inhalation anesthesia. I think that may be true. We pre-treat intraop with ondansetron or an equivalent, and dexamethasone, particularly for high-risk surgeries. One of my colleagues is starting to use a drug called aprepitant, which I haven't used yet, but is reported to be even more magical in preventing post-op nausea and vomiting. Other than that, we'll sometimes see a difference if we manipulate the recipe of a PCA pump. A smaller bolus dose less often, or turning down or turning off the background and leaving them just with the bolus sometimes can improve post-op nausea. But there's still patients who we just have no idea, and we don't know whether it's related to our drugs or related to the surgery or what it is. So we puzzle over those just like everybody else does.
Right. Thank you very much. Prof, there is a question from Zara Serpil. Is there a way to measure perioperative pain that you would strongly advocate for in pediatrics? For example, like the NOL in the adults. And are there any studies that you can think of that would validate those?
There are hundreds of studies on pain assessment, which applies to postoperative patients as well as other types in children. Our psychology and nursing colleagues in particular have been particularly skilled at bringing science to this issue rather than just guesses. The FACES Pain Scale Revised, which I actually showed in one of those slides, is available on the ISP website, has instructions in, I think, 45 languages now. If we're missing any, and any of you there want to provide an additional translation, that would be great. That, to my mind, has got the best psychometric data and the best concept, best validity of the FACES scales for self-report. There are other techniques for self-report for younger children. There are behavioral observation scales like the CHEOPS and many others. The problem with those is that your behavior attenuates faster than the pain attenuates. So if you have acute severe pain, you cry and complain and show it physically, but if the pain continues, you don't keep doing those behaviors. As a child, you tend to curl up and ignore the world. So that makes those observational scoring systems less effective over time. So they're a little risky because you say the score is better, therefore the patient must be better, but it's really just the patient's ignoring you because you're not doing anything for him. Self-report's always best, and even a 3-year-old can tell you whether it hurts a little bit or it hurts a lot if you ask him the right way. I've got a whole 1-hour lecture on this topic, if you like.
We'll have to reserve that for another time.
Yeah. But most importantly with kids, if you're asking them whether it hurts, they have to know what the implications are. If they say, yes, it hurts, are you going to give them a needle? Are you going to operate on them again? Are you going to keep them in hospital? So you have to be very clear with them that they understand that you just want to give them a little medicine to drink or in their IV that will make them feel better if they have pain. That's one of the most important stumbling blocks.
Prof, can I just ask, so Dr. Serene Lim has also asked a few questions, and this is also with respect to how would you say you would rely predominantly on pharmacological or psychological methods of management of perioperative pain in young children?
Yes. Both. You can't just highlight one or the other. Acute trauma, surgical pain, you really need drugs. But that doesn't mean you can ignore the psychological part. And there's actually been not enough research on what psychological preparation can do for postoperative pain. Study done by a graduate student of my colleague Pat McGrath many years ago found patients' pain after third molar removal correlated with their expectations of what their pain would be pre-surgery. So Melanie Knoll in Calgary has done some brilliant work on pain memory and how memories can be adjusted based on how you talk to children with respect to a procedure. And I strongly recommend her work to anybody who's interested in this. Noel, Melanie Knoll. She and many brilliant graduate students working with her have done a number of really important studies.
Excellent. So, Prof, that has been really educational. Thank you so much. We actually have a whole host of more questions, but in the interest of time, I'm just going to hand the stage over. But before I do that, Prof, we'd like to give you a virtual round of applause for giving us such a great overview of how pain has been improved over the years in the children. All thanks to the many dedicated pain physicians like yourself through the years. Thank you once again, Prof.
Thank you so much. It's been a pleasure and an honor to be here. And
it's been great to have you.
Anything I've done has been a result of connecting with smarter people to work with. That's always been my key.
That's good advice, and we should all take that on. Bye, okay. Prof. Good night to you. Thank you.
After an invigorating morning with Professor Soriano and Professor Finley, we will be taking a short break till 11 a.m. Singapore time. After the break, there will be 3 tracks running concurrently. Stream 1 is the pediatric pain track, featuring the pain management journey of a little girl with cancer from diagnosis to surgery and rehabilitation. Stream 2 is a pediatric trauma track, providing insights into pediatric trauma in Asia from the golden hour all the way to outcomes. In Stream 3, we will have the pediatric cardiac anesthesia track, exploring the future of pediatric cardiac surgery in Asia and the role of viscoelastic testing. Thank you, and see you all after the break at 11 a.m. Singapore time.